Thank you so much. So yes, Max Almond. I don't recognise any of you, but I'm a consultant surgeon in Birmingham, and I've trained all over the West Midlands and also at the Royal Marsden and also in Milan. So I haven't been to one of these meetings before, but I thought I'd be very happy to come and speak, and I know all of you perhaps have had GIST and at different stages in your treatment. So I thought I'd just talk a little bit about GIST. I was part of the team that wrote the national guidelines for GIST that were published in 2024. So I'll maybe comment on some of the changes that have come in. And also, hopefully, I can just answer any of your questions as best I can. Now, I am a surgeon, so my expertise is in operating rather than the oncology side, so I'll do my best when it comes to any oncology-type questions you may have. We all know that GIST is a malignant tumour that can affect anywhere in the upper gastrointestinal tract. Commonest place is the stomach. But we also see a lot of small intestinal GIST, as we've heard there. Quite often patients are diagnosed with a tumour in their pelvis, which is thought to be ovarian, but actually it's attached to a piece of small bowel, and we find out it's a GIST. We see some very huge GISTs, and sometimes it can be difficult to know where they're originating from, but certainly stomach, small bowel, and less commonly rectum. And then very uncommonly we might see other places such as the colon or the appendix or the esophagus. We know that it's a relatively rare tumour, so there's about 800 to 900 patients per year diagnosed with GIST. So it's not as rare as some of the other things, some of the other tumours maybe I treat at University Hospital Birmingham, but it is relatively rare when we compare to things like colorectal cancer, breast cancer, and therefore sometimes funding to run trials can be more difficult for GIST as it is for other rare tumours. So how do people present? I think you will know this better than most. Presentation can be very variable, so we do a lot of scans and ultrasounds and CT scans for non-specific symptoms, and often these days GIST can be picked up incidentally, so you could be scanning to look for gallstones, you could see an abnormality and it turns out to be a GIST. But also patients can present with symptoms, so you may have a mass in your tummy that you can feel, you might have lost weight, you might present with bleeding, so GIST can bleed into the gastrointestinal tract, and therefore you might vomit blood or see blood from the bottom, or you can present with anemia. There can also be emergency presentations, so sometimes GIST can perforate and people can come in very septic and sick with peritonitis. We have to operate as an emergency. And there can be less specific features such as weight loss and other non-specific tiredness and lethargy that maybe prompt a CT scan, and then the GIST is discovered on that. So what do we do when we find someone with a suspected GIST? Well, thank you. The first thing we do is we want to establish a diagnosis. The way that we can really inform people about their prognosis and about how what treatment they need is once we understand exactly what we're dealing with. And as we've heard just in the comments since I've been here, sometimes these tumours can be mistaken for others. There's a lot of other types of unusual tumours that can look like GIST, and because they affect any part of the gastrointestinal tract, they can be quite non-specific, and we'd see a lump and we're not sure what it is. So in order for us to really be able to make a clear treatment plan for a patient right from the start, we want to establish the pathology, and that means a biopsy. Now, GISTs are a bit different to your normal typical carcinomas. They're actually sarcomas, so they're malignant tumours, but they arise in the sort of wall of the gastrointestinal tract rather than from the lining of it. And so usually if you're talking about, for instance, a rectal or gastric GIST, if you go down with a normal endoscopy, you might see a bulge, but you won't necessarily be able to just take a biopsy of it because it's actually deeper, it's hidden below the mucosa, the lining of the stomach. So we actually use what's called endoscopic ultrasound, and that enables a sort of scan during the endoscopy, and then a needle is passed into the tumour under ultrasound guidance, which then gives a diagnosis. Now, some people have a large abdominal mass, in which case it may not be possible to or necessary to put a camera down or up, and instead what we do is just do a scan of their tummy wall and pass a needle directly into the mass. But it is generally much better if we can establish a tissue diagnosis before we operate, because, as I said, it informs us, and also, as I'll come on to in a minute, it informs whether or not we think about giving neoadjuvant treatment, which is treatment before surgery. In some cases, though, there may be, typically with the small intestinal GIST, that might be 2 meters down from the mouth and 2 meters up from the bottom, and we simply can't reach it with an endoscope. And if it's too small for us to be able to safely access by passing a needle through the tummy, it might be hidden under other bowel loops that we can't get to, because we'd hit those bowel loops if we tried to put a needle. So in some cases, we just have to go in and operate and remove it, on the assumption that it might be a GIST, we're not sure, but it needs to come out. So once we've done a biopsy, which is clearly, as I said, plan A, we're interested in confirming the diagnosis, and what they do, they look at it under a microscope, and they do some immunohistochemistry on it, which means they do sort of a lot of stains, and there's a characteristic pattern of stains that point towards GIST. And of course, nowadays, we also do mutational analysis, because that's really important for informing our treatment decision and our prognosis of the GIST, and whether this might respond to neoadjuvant imatinib therapy, or whether we should be thinking about post-operative imatinib. So we try and get mutational analysis done right away, even on the biopsy, and certainly when we've taken it out. We then do staging. So the standard thing would be a CT, chest, abdomen and pelvis with contrast, and that makes sure that there's no evidence, hopefully, of the disease spreading elsewhere. We know it's very uncommon for GIST to spread to the lungs. It can happen, but it's very rare, but we tend to include the lungs in the staging scan. But GIST can spread more commonly to the liver and to the peritoneal cavity. So we've got to have a really close look for evidence of spread elsewhere. And sometimes also we use other scans, such as PET scans, and PET scans are another type of good staging scan, but they're also useful later down the line for assessing response to treatment, because GISTs are what we call FDG avid, which means they light up very brightly on PET scans. And actually, after giving treatment, medical treatment, imatinib, often the tumours become less avid and shrink, and even aren't avid at all, so they won't glow up anymore, and that's a really good sign that they're responding to treatment. So a PET scan is very useful in GIST. And then sometimes, depending on anatomically where the tumour is, we also use other things like MRI scans. And then when we've got all that information, we sit together in our MDT, and we do that every week. I did it on Thursday this week with my oncologists and other surgeons, pathologists, radiologists in Birmingham. And we look at, and we had, I think, 79 patients to discuss this week, not all with GIST, but with a variety of rare tumours. So it's a big meeting, and we go through everything in detail, and we look at all the images, then tie those in with the history of how the patient's presented, and the pathology results that we've got, and the mutational analysis. And then as a team, we agree that this is the right thing to do for this patient, in our opinion. And sometimes there can be differences of opinion. And sometimes we also say, well, look, some of these decisions are up to the patient, and we need to meet the patient. We need to have that discussion, explain what we're dealing with, look at the scans with the patient. And then it's a sort of, you put the risk benefit, and you say, look, what do we think here is the best? So MDT discussion is really important for GIST, because these are complicated tumours. They affect different parts of the body, and we just need to make sure that everyone's on the same page and we're doing the right thing. So if we talk about local disease, that's disease that hasn't spread, and of course how we treat disease that's metastatic at diagnosis is a bit different to how we treat disease that hopefully is confined or resectable. And usually plan A, if we find it, when we find a GIST, is to operate and remove it. Now there's a few exceptions. If it's an elderly patient of 83 years old, or it's a tiny little GIST in the stomach that's very low risk, we might say, okay, we just keep an eye on this. It's only 1 centimetre and it's probably not going to cause any problems. But the vast majority of patients, when we find a tumour, provided there's not widespread disease, we go on and operate. But there are exceptions to that. If this is a massive tumour, 10 or 20 centimetre tumour, maybe it's involving other structures inside the tummy, maybe it's arising from the stomach but involving the pancreas, the diaphragm, the spleen, the kidney, the colon, we might think, well, surgery is an option, and we do quite a lot of those operations in Birmingham. But actually, we'd rather try and shrink this down a little bit first if we can. It might just make the operation a little bit safer, might give us a better chance of a clear margin. It might mean that we don't have to resect pancreas, for example, anymore, which will limit the risk and the morbidity to the patients afterwards. So that's where the mutational analysis comes in. And as you know, we're looking for potentially sensitive mutations, such as the most common mutation, which is the mutation in exon 11 of the c-KIT gene, which, again, as most of you will know, we would expect to respond well to treatment, either preoperative, neoadjuvant, or adjuvant postoperative. The other reason we might think about preoperative imatinib is dependent on the site of the tumour. So if you've got a tumour that's even relatively small, but it's right at the gastroesophageal junction between the esophagus and the stomach, really the only way to take that out is to remove the whole stomach. And that's quite a morbid operation. It has risks, and it's also not very nice for patients for the rest of their life to not have a stomach. And therefore, we sometimes in those settings think, well, if we can take that tumour from 6 centimetres down to 3 centimetres with some imatinib, might just give us an option to just shave it off the side of the top of the stomach rather than needing to perform a total gastrectomy. So these are the sort of thought processes that we're having when we look at it in MDT. What type of operation? Is it resectable? How easy is the resection? How morbid is the resection? In other words, how are we going to leave the patient afterwards? What risks are we going to put them through? And if it is high risk, could we think about downstaging, and is it a sensitive mutation? Yes, we can probably go to the next slide, please. Now we know, now once we've removed the tumour, the pathologist analyses it, and they will tell us in our MDT, based on the histology, what risk category it falls into. So and there's 4 risk categories. We'd be told, based on the site of the tumour, its size and its mitotic rate, we'd be told, is this a high risk GIST, intermediate, low, or very low risk? And that's important because not only does it inform prognosis for the patients afterwards, and that's what patients want to know when they come back to speak to me, but it also informs the treatment and the surveillance plan that we do. So if it's a very low risk GIST, in theory, we don't need to keep those patients under surveillance. Sometimes we say, look, okay, we'll arrange a scan in a year or two's time, or a few years' time, that's not unreasonable. But technically speaking, really, based on the data, those patients can be safely discharged. The low-risk GISTs we would keep under surveillance, and the same with intermediate-risk patients. But those in the higher-risk category should, if they've got a sensitive mutation, be given adjuvant treatment with a tyrosine kinase inhibitor. And in fact, we know that surgery alone, you would think that removing the tumour, we surgeons go off and are very pleased with ourselves. Yes, we've taken it out with a nice clear resection. But actually we know that in the high-risk group, the risk of that coming back if they don't receive any subsequent treatment is actually quite high, and the survival rates are relatively limited, about 50% at 5 years. But if we give those patients adjuvant treatment, so we can move to the next slide, we can actually significantly decrease the risk of that tumour coming back and increase survival. So if we give 1 year of adjuvant imatinib, we can increase the survival at 5 years from 50% to 80% or 81.7%. And in fact, if we give 3 years of adjuvant imatinib post-surgery, the survival for the same high-risk patients becomes 92%. So it shows how important these drugs are in helping us provide sort of curative treatment, hopefully, for our patients. And I think, next slide, I think we know that there are there's an ongoing trial looking at actually if we give even more imatinib, 5 years, even in an adjuvant setting where patients have had a successful operation, will that increase the survival benefit even further? And this study, I think, isn't going to report towards the end of the decade, but it's still, the people like Robin Jones from the Marsden are absolutely up to date with how it's going in terms of what the preliminary data is showing us. Yeah, next slide, thanks. Now, metastatic disease is a little bit different. Of course, we don't tend to operate for metastatic disease. That means disease that's spread elsewhere, albeit that's caveated by saying it depends on the pattern of disease. So if we've got 2 or 3 sites of disease, then we may well say, look, there's a surgical option here to go and take all of them out. Obviously, if there's disease in lots of places, then it would just purely be medical treatment usually. But how would we address this? Well, if we saw a metastatic patient at presentation, we would give them imatinib, provided they had a sensitive mutation, and that would be, and the dose of imatinib might depend slightly on what type of mutation they had, and then we'd monitor them either with PET scanning or CT scanning. Now, if that tumour, what we'd hope to see, for instance, on PET, is that the tumours that were originally lighting up become quite dormant. They start to shrink. They start to not show avidity, so not light up anymore. And then we might monitor those patients, and at some point we might say, look, there's an opportunity here to go in and operate and remove everything that we can or everything that we can see. The other thing that sometimes we do is we say, okay, we're going to keep them on imatinib and keep monitoring closely. And sometimes patients might have 5 or 6 areas of disease, and the imatinib's working, but on one site, it starts to light up again on the PET, and you see, and you think, actually one of those tumours is starting to now become unresponsive to imatinib. And then we've got really 2 options. One is that we switch to sunitinib and get control again, but the problem is, as you know, there's only a certain duration of time that we can give these different drugs without the same thing happening. So the other option is that we maybe can say, okay, well, this one area is lighting up again, let's go in and take that bit out, because that's the bit that's causing a problem. The rest is still under control by imatinib, and that way we take out the bit or the 1 or 2 bits that are lighting up. There might be another year or 2 or 3 before any other areas start lighting up. And again, if it's a single area, maybe we could take that out. So these are sort of, again, thought processes that we have. So, yes, so maybe we'll talk about just a couple of cases. If you just press on the next. So this is a man, so because there's a video, yeah. So this is a man in his 50s who's referred. He had this big mass here. And I think he had a palpable, it came with a palpable lump in his tummy. And you can see why, because it's very large. And he went to his local oncology team. They put this is one where you don't need an endoscopy. You can just put a needle straight through under ultrasound guidance into the abdominal wall. And then through into the mass. So he was diagnosed with GIST. It was exon 11. He had a PET scan, he had a CT scan, he was staged. Now, unfortunately, he did have several sites of disease, so he had this big area, but actually when you looked closer at the CT and on the PET, there were 3 or 4 other areas of disease as well. So quite reasonably, his oncologist started him on imatinib. And if you go to the next slide, and this, I think that's the PET scan, so that just shows that the power of the PET scan for showing up these hot areas. Now, this is sort of dead tumour in the middle, but this is clearly an abnormal tumour there with active tumour in the walls of the mass. And then next slide. And so we gave this patient, or his local oncologist gave this patient imatinib quite reasonably, and then he was referred to us in Birmingham to say, actually, he's responded really well. And actually, the area that we saw before, so this is his kidney, so this is meant to light up, but this tiny little subtle area was that big tumour from before, and the other areas of disease that were inside the tummy completely disappeared. We couldn't see them at all. So the oncologist quite reasonably said, actually, would you now think about operating for this patient? And the answer to that was yes. And I saw this chap and he's quite fit. And the question that really is timing. Do we operate now while we have an opportunity? Do we wait and sort of sit, and if it starts to show some avidity again, then take it out? But I went ahead and operated on it and removed everything I could see. There's a couple of little other areas of suspicious disease that were probably these other areas which I took out. I took that mass out with his right colon, and he's done very well so far. So it just shows the power of imatinib, even in seemingly quite extensive big tumour, multifocal disease, but we could still now get to a point where we could remove it and hopefully leave him disease-free. That's not to say he won't have recurrence of disease, and we know that our job isn't to pretend to him. We know that the risk is significant that it will recur at some point, but being macroscopically disease-free at this stage is surely a good position to be in now, given how he came to us originally. So when should we think about surgery for patients with metastatic disease? Well, this is what the national guidelines say. If there's shrinking or stable disease on imatinib, we can think about going in. As I've said, if someone's had imatinib for a while and one or two areas start to grow again, maybe we can go in and take those out. And then the other time that we do contemplate surgery in metastatic diseases is if there's an emergency, if someone bleeds or if the bowel looks like it's imminently going to obstruct or burst, then obviously we might think about surgery. It's difficult to look at to sort of assess this in randomized trials, though, because as you can imagine, if someone's offered the option of surgery versus do you want to go into a trial, have an operation or don't, vast majority of people will say, actually, I don't really like the sound of that trial, I just want to go and have a surgery and get it out. And we've got to be very mindful that sometimes we can put patients at risk of worse quality of life and put their life at risk in theory by doing a big operation when maybe it's not the best thing to do. And also we've got to be mindful that sometimes when you do a big operation on patients, it knocks them about a bit, so that some of the other dormant disease might flare up a bit quicker than otherwise would have been the case. So sometimes you go in and you stir things up a little bit, you think you're doing the right thing, but actually some of the other disease can wake up. So we've got to be mindful of these things based on evidence that's not really, really robust, but based on a combination of the evidence we have and experience and the patient's wishes. And ultimately we talk to the patient, we look at the scans, everyone's history is slightly different, and that's what makes it challenging but also interesting, and we say, look, these are the options, we think we can get in here and get this out quite easily, relatively low risk, I think we should do it. Or maybe we're saying the opposite. So this is another patient. That was the tumour here. So on this time, these are some small bowel loops. So in this one, we couldn't actually get a pre-op diagnosis, I don't think, because it was sort of hidden in the pelvis underneath some small bowel. So we'd have had to skewer through the small bowel to get to it, which obviously we don't want to do. So we saw this and we thought, well, we're not sure what it is, but it could well be a gist. It probably is a gist. Let's go in and take it out. So it's a keyhole operation, find it, remove it, and then there did need to be a cut a certain size to get the lump out at the end. And then the surgery here was very straightforward. And if you move to the next slide. And this was actually a high-risk tumour. We know that small bowel gysts are it tends to be a higher risk location for GIST maybe than the stomach. So usually stomach tumours, unless they're very large, tend to be lower risk than some of the small bowel ones, not always. But this was a high risk, but it was exon 11. And therefore, of course, based on what we've said before, we recommended 3 years of adjuvant imatinib for this patient after a successful surgical resection. If it was intermediate, we would have just kept under surveillance. So if it's an intermediate risk, we would have said not for imatinib, we're just going to keep you under surveillance. If it had perforated though, so let's say she'd come as an emergency, that would again been different, because once these tumours perforate, they spread the disease inside the tummy, and that would be classed as metastatic disease, and there'd be a high chance of this coming back. So we'd definitely go on to imatinib, and the difference there would be she would have imatinib forever, for life, until the point where there's progression, then it would be switched. So we wouldn't be time restricting imatinib at all in the setting of a perforated tumour. If it was an R1 resection, which means there's some tumour abutting the resection margin, and there's a suspicion that there might be some microscopic disease left behind, we would still treat that as we would as a completely excised tumour, which sounds a bit odd, because you think if there's a chance of disease left behind, you should give imatinib, but that's not that's not sort of held up by the data. So in other words, the data suggests that as long as it's macroscopically clear, there's no visible disease left behind, these patients can do very well. If it was R2, which means actually some disease left behind, I'd be thinking, well, we need to go in, and sometimes we see this, that patients had an operation, it may be in an acute setting by a non-specialist surgeon, and there's disease left behind. I'd be thinking plan A here is to go back in and get it out. And it might be you give some imatinib, shrink it a bit, make it a bit more straightforward, and then go in and take it out. But certainly this would be classed again as having disease inside, so those patients would stay on imatinib unless we could get that disease out surgically. And then there's more complexity, and this is where the sort of molecular side comes in. It's really important to understand the mutations that people have with GIST, because yes, exon 11 can respond well to tyrosine kinase inhibitors. Exon 9 a little bit less well, but we would still treat with potentially higher dose. And then the complexity comes through for the sort of wild type GIST, the SDH deficient GIST, or the D842V mutations, and these we tend to think of as less aggressive tumours. Not that they can't be aggressive and can't metastasize, and of course they can, but maybe less rapidly progressive if you just leave them alone. But the downside for these is they don't respond to conventional imatinib. The SDH deficient tumours in the palliative setting, so in a sort of metastatic disease setting, we would treat with sunitinib, although it doesn't respond well to imatinib. The D842V tumours, we don't, again, use adjuvant treatment for these. We just operate, but if there's recurrence or metastatic disease, we might watch them for a while to see. It might be very, very slow growing, but then also we might look to use avapritinib. Okay. I haven't really talked much about surgery because I wasn't quite sure how to, well, I thought I'd just give an overview really of GIST, and hopefully what I've said so far is interesting, and you may know a lot of it, but hopefully it just sort of helps you understand the condition better. I wasn't necessarily wanting to show you gruesome pictures, because I think that even if 9 out of 10 of you might have not have minded, there might be some people that wouldn't have wanted to see that. But I will just say that there are a number of different ways of doing surgery. Now, my view on this is that what you really want is a really high quality, careful operation that removes the tumour fully. So if the way to do that is with an open operation, that's what we do. What we want is to make sure the tumour's out, make sure the patient does really well, and they go home. No one's going to die from a cut in their tummy. They'll die because you leave tumour in, or there's a complication because you've got a lot of surgical ego and you're trying to do something over clever and over fancy. So that is a fundamental principle. But in many cases, we can. Obviously, it's much nicer for a patient to have keyhole surgery than a big open operation. So if we're having to take pancreas and diaphragm and en bloc with the kidney and the spleen and the colon, that's a big open operation. But if we're taking a smallish, just 5 centimeters that's hang off the side of the stomach, then that should be very easy to do laparoscopically, where we blow the tummy up with carbon dioxide, we put some ports in, and effectively we just lift the tumour and put a staple gun across the side of the stomach, and that both cuts it off and also seals the stomach, and then the job is done. You pop it inside a little bag and you make a cut just big enough to pull it out, and you take it out, and that's very straightforward surgery and usually very low morbidity, and patients go home very quickly. There's also endoscopic options. So sometimes now for tumours in the stomach and certainly in the rectum, we try and do these procedures endoscopically. So up the bottom, for example. Problem with doing a low rectal gist operation is when you remove the rectum, you try and join the bowel back together, but the low rectum doesn't heal very well, and it can be quite a morbid operation, and sometimes they're so low that you end up having to cut the anus out and stitch it up, and then they have a permanent colostomy. And of course we do that, and a lot more people than you realise have stomas, and they can be managed very well, and ultimately if that means the patient's alive and cured, then 100% we would do that. But actually we try more and more to shrink these tumours down and then do them endoscopically. So put patients to sleep and then through the bottom sort of locally excise the tumour with a special camera through the bottom. It's called a TEMS procedure. And then close it again, stitching through the bottom. And this is really effective actually for rectal gists. So whenever we can use that as an option, we do. And then the other emerging, or not so much emerging, but increasingly used approach is robotic surgery. And when we talk about the robot, we're not really meaning artificial intelligence. So it's not the robot that's doing the surgery. The way we set it up is like in the pictures here. So we put the patient to sleep in this conventional way. The surgeon comes to the table and we blow the tummy, we make a little access, we blow the tummy up with carbon dioxide, and we put 4 or 5 ports in, and then the robot connects to those ports with its robotic arms like this. And then the surgeon takes off their gloves and their sort of sterile outfit and goes and sits in the corner at a console like that. And then with their hands, they then control the robotic arms that are inside the patient. And the idea of that is it's then much more like open operating, because the robotic hands can twizzle and can do this and can do all the things that I could do if there's a big cut in the patient's tummy, but through a tiny little port. So you have much more dexterity than you would with conventional laparoscopic instruments. Also, the view is fantastic. It's all HD and it's absolutely clear and it's magnified. So you can be really, really precise, and you can do some really fantastic surgery using the robot. We've got to be mindful, of course, there's no point trying to take out, doing a real fancy dissection and then making a cut this big to get the tumour out at the end. So there's no point really doing robotic surgery for a tumour this big. But certainly for tricky tumours at tricky sites, it's much, if you're taking a tumour out that's maybe this big, it's much better to do it with robotic and then maybe reopen the old appendix incision that the patient had, or a C-section incision from 20 years ago, and use that same scar, take the tumour out, and then it's done. So these are the types of things that will be increasingly coming on all over the place, and certainly robotic surgery is definitely the future. It's just expensive, so that's why it's not necessarily used everywhere. Okay, next. Oh yeah, and that's the console. I mean, the potentially amazing thing about this is you could dock the console. You could have a console like that in that corner, and I could operate on someone that was in Birmingham from there. So it is quite amazing. And I think people have done it like transatlantic. I think someone from the US has operated in someone, in Europe or something. Okay. So I think GISTs are really challenging tumours. They're not common. A lot of people don't have experience of them. They can range from being tiny and easy to treat to really difficult, big, multivisceral resections, metastatic disease, liver resections being necessary as well. They can be, as I said, anywhere from the esophagus all the way down to the rectum. And there's opportunities for sort of complex molecular biology, a variety of different oncological treatment options depending on the specifics of the tumour. So this is almost more than any other cancer, so important that you work with a really good team with expertise. And that isn't just the surgeon and the oncologist, but it's the pathologist that works out what it is and the type of mutation that's there. It's the nurse specialist that can support the patients because they understand and they see a lot of patients with GIST rather than just seeing one a year. It's a radiologist that can call, we think that is a GIST, or that are experienced at doing endoscopic ultrasound or experienced in safely getting biopsies. It's the full set of team that's really, really important here for making sure that patients have really, really good outcomes and good experiences as good as possible. Okay. I think I've probably said that. Thank you.
I build houses for a living, and you've just made that sound as easy as building houses, but it was incredible, absolutely fascinating. As I say, I was asleep when I was operated on, as most of us are. We don't get to see it, so to listen to the detail that you've just given, it's really, really interesting. Thank you for that. So, any questions?
Thank you, that was very interesting. I'm one of the various cases in the room who's been diagnosed as having a GIST, which has metastasized across the liver and quite a few sites, one of which was quite large, and therefore I've been branded as inoperable, and that's been the advice to date. And I'm thinking of your case 1, where you had a patient who was KIT exon 11, had responded very well to imatinib, and you decided that you could operate on him and remove some of his tumours. So from your perspective, what are the features of a tumour that would encourage you to go in and operate in a case like that?
Well, the liver is a little bit different because of the nature of this, how much disease is there. So we need to always be mindful of how much liver we're leaving behind. So if there's multiple areas of disease across the liver, it might say, well, look, we can't take all of these out because you wouldn't be left with any liver. But equally, if there's one on, or if there's 2 or 3 bulky ones on the right side of the liver and only dormant disease on the left, then you might say, well, look, let's do a right hemihepatectomy, take out the right liver. It'll grow back anyway. That's an amazing thing about the liver. But again, that needs to be balanced against how well you are and your prognosis without surgery. So we might say, well, look, that's quite a big operation to do, actually. It's it's not like, again, if it's a left lateral segmentectomy, that's a really easy operation to do and can be done with keyhole surgery. We just snip that bit of liver off and off it goes. I'm sure that would be the right approach. But if it's an extensive liver resection in someone that's where we're not going to clear all the disease, we might be expecting other bits to start to turn on at some point anyway. We've got to be mindful of that. So I think that hopefully I don't know where you're being treated, but they will know all this, and I'm sure you've probably had the conversation to say, look, and you've probably seen oncologists, but they will know this. They're not necessarily they're a bit different to surgeons, but they will always discuss the case with surgeons if needs be. So I think that there's a bit of complexity there. It's not necessarily a case of, yes, remove everything you can see, because sometimes that can make matters worse, or it can be a big operation, or it can leave you without sufficient liver to function normally. So every case is nuanced. And to answer you specifically, I need to have a look at your scan, obviously, but that's also why people sometimes ask for second opinions, which is an entirely reasonable thing to do. And in fact, that should be encouraged, because sometimes we have taken quite a few patients where they've been told they're inoperable, and not so much for GIST actually, but for other rare tumours. And we've said, well, we're going to take it out. So sometimes people, other areas do, different specialists do differ slightly. That's not to say we're right, and I think there's probably some cases where we've got that wrong and we've taken it out, and probably it hasn't actually offered the patient any much benefit because they get disease recurrence or whatever. But some cases I think have benefited from that. So that, I suppose, would be my answer to you, which is you're right to always question and think about the options. And if you're not sure, and if it's one of these where it's a bit 50-50, by all means ask for another opinion from one of the big specialist centres.
Any more questions?
Hi, just talking about the liver in particular, do you do CERT type procedures?
So it is an option. So what we would normally do in reality, so I have trained in hepatobiliary, but my subspecialty now is in rare cancers. So I don't do liver surgery myself anymore, albeit that was my training.
Can you explain CERT?
So what we would do is I would refer you, if we're thinking about CERT or RFA or any of the other options available for liver intervention or surgery, we would refer you to our liver MDT, and they would look at that and they would say, look, what options are best available for this person? So yes, possibly, but I'm not probably the best person to ask about that, but that's more of an oncology question.
Hand up there. Yep.
Thank you. With robotic surgery, does that allow for a finer margin? And as a follow-up question, I read in Japan they're using radio markers prior to using the robotic surgery. They introduced the radio markers endoscopically. Is that something which is carried out in the UK yet?
Yeah, so sometimes the sort of radioactive markers are used to help define the blood supply of the bowel that you're cutting out to help minimize a risk. So although it can show the tumor, it can also show you that the remaining bowel that's left behind is well perfused, so that it minimizes the risk of the joint in the bowel not healing. So that is something that we are sort of using experimentally a little bit. Again, all these things cost some money. So I was at a dinner the other night where the people that do this technology were trying to encourage us to get it in Birmingham. And of course, me and my surgical colleagues all said, yes, that would be fantastic, we want it. But of course, actually making that happen costs money and is difficult. So yes, we potentially would like that. With the robot, I think that the view it gives, the extra dexterity it gives is fantastic. And I think that as experience of the robot increases, we will be able to take on more and more complex cases with this form of minimally invasive surgery. Having said that, as I said at the outset, I'm a bit old school because I also do some big sarcoma cases that are massive, like this size, and obviously you can't use a robot for those. So I'm still of the opinion that ultimately it's the quality of the oncological operation that's most important, but if you can do that with equal quality with a robot, then a robot is obviously better, and 100% it gives advantages over conventional laparoscopic surgery. So I would hope there shouldn't really be any reason to leave a positive margin unless you've got a very, very extensive tumour.
Just a question, because you serve quite a big area and you are a specialist hospital. So a rough idea of how many GIST you actually have to, it comes through you, and is that on the increase?
I think it probably is, but that's because of the change in referral patterns rather than necessarily because there's more GIST in the country. I don't know is the answer. Are there more GIST now than there maybe were 20 years ago? Possibly, but again, is that a real thing, or are we just finding more because we're doing CT scans every 5 minutes when someone comes with appendicitis, versus in the past when we didn't used to do that? So how many do we treat? We treat quite a lot, and also I work I'm in a sarcoma unit, but also the way it works with GIST, because a lot of them come through the upper GI unit as well, if they're gastric tumours, and that was the traditional way that we used to do it for GIST. There'd be a gastric tumour, so they go to someone that does gastric cancer. So we work very closely, and we're in the same team as our gastric cancer surgeons. So any of us can operate for GIST. If it's multivisceral and it's not in the stomach, then they would refer to us. But if it's in the stomach, they would get on and take it out. So how many? I don't know. I'd be guessing. Yeah, I'd have thought a reasonably significant proportion, I would think, because we're a big unit in the centre of the country. But our sarcomas, for example, come from the whole of Wales, Leicester, Nottingham and Addenbrooke's, whereas Addenbrooke's definitely, and Leicester and Nottingham take out their own GIST. They don't need to refer them to us. In fact, Addenbrooke's, as you know, is an excellent centre for GIST. So we don't get as many, our geographical area is the West Midlands really for GIST. It doesn't go outside of that because usually it's not necessary, but we get the odd one where it's a really big multivisceral type tumour, or there's uncertainty as to what it could be, and they come to us from outside the West Midlands.
We're seeing on the data we've been told around 900 a year, and that hasn't really changed a lot over the last 10 years. But as you say, more are being diagnosed that may have been there before but just not diagnosed or reported. But data's getting better, and I think the rare cancers bill for all rare cancers will mean more data will be coming forward as well. So, any more questions? They're making me walk today, aren't you?
I understand GISTs frequently metastasize to the pelvic peritoneum, which is in fact my own circumstance, with several lesions up to about 10 centimetres. What's your decision making as far as surgery is concerned in that area?
So that's actually similar to the first case I showed. He had that big one, but he also had 2 or 3 other smaller ones in the pelvis. I think, again, the decision making on that, it depends on how you are and how it's responding to imatinib. But if you've got lots of disease, then we wouldn't generally go in and take that out, because the concern is that for every one that we could see, there'd be another 2 or 3 that we can't yet see. In other words, we see the ones that are 3 centimetres, but there might be some sub 1 centimetre, and there's no point taking out 3 or 4, putting you through an operation, take out 3 or 4 4-centimetre ones, when actually there's also another 5 or 6 tinier ones, because by the time you've recovered from that surgery, the other one, and we've paused imatinib and all the other things, the other ones will have grown to how big these were. So that's and it's an upheaval, and it's unpleasant, and it's risk of surgery and everything else. But as I said earlier, where we might think about operating is if you have 5 or 6 or 7 sites of disease, and they're all FDG avid on PET, and then you start treatment and they all turn off and start to shrink. And then over the course of monitoring, if one of those or 2 of them switch back on, and you think, well, these are all dormant, but this one is problematic and enlarging, then we might say, well, look, there might be an opportunity to take that one out, because that one's clearly more active, more aggressive, and is no longer responding to imatinib. Rather than switching to 2nd line or 3rd line treatment, let's take this one or these 2 out. So that certainly could be an option. And that's a sort of approach that I took with that first patient.
Okay, thank you. Anything else to add? Any more questions? Oh, yeah.
Hi. Do you know how you said, like, if they were all dormant on the imatinib, then should I know it's about me, but in general, I've just before Christmas they found between the rectum and the womb, one was playing up and reflared. So instead of giving me an option, because mine's metastases in the peritoneum, small intestine, shouldn't they have offered me maybe to remove that wild one and then keep me on the imatinib when the imatinib was working all along, instead of switching me straight away to sunitinib? And now I've had sunitinib for 6 months. Obviously, I'll find out that if it has shrunk, and then I've got surgeons saying that maybe they'd remove just that one gist that's not reacting because all the rest is still dormant, to have an operation and just remove that one gist. Would that be worth anything when it's still in the liver and the peritoneum to go through all that, or it wouldn't be worth surgery?
Yeah, that's a really difficult question, and that's what I was sort of saying, that there isn't any randomized control trials, because it's very difficult, because, you know, patients often, if you mention the option of surgery, they want to go for it, and certainly, but we don't know in a case like yours potentially whether you would have benefit to your quality of life, to your long-term survival. As a surgeon, obviously I want to operate when I can, but equally if you've got lots of other disease, sometimes stopping imatinib or stopping sunitinib, the upheaval of going in there, taking out the one that's lit up and become active, and then you recovering, that can sort of stir the others up and make matters sometimes worse. So I think with this type of thing, it depends on sometimes the extent of the surgery necessary. So if we've thought actually you're a young and fit patient, it's just sat there, we can get in and take this out relatively straightforward, you've not got a really scarred abdomen, then probably the risk benefit might say, look, there's only one that's lit up, the others are dormant, let's think about it. Or you might say, look, switch, get control of it again, but then with a view to going back in and taking it out. But if it's going to be a really big deal to get in, let's say a overweight patient or lots of cardiac problems or really scarred abdomen from before, and you think, oh my goodness, just getting there is going to put the patient at risk, it's going to be a long operation, it's going to be difficult, or they're old or whatever, then you might say, well, look, there's no really a surgical option here. So there's it's the patient factors, how big the operation is, their surgical history, the number of sites of disease, the pattern of how the disease is progressing, and it's so nuanced in terms of decision making. But I think that we certainly, the GIST centres that do a lot of GIST are quite bold in thinking about all the options, rather than just sort of saying, oh, well, look, you've got more than one site of disease, there's no surgical option, or there's no option for ablating it or anything else. So as I said before, you know, it's never a bad thing to say, look, have we thought about the option of surgery? Could I maybe have a second opinion? I'm not saying, but it might be that you do that, and the ultimate decision is, look, in your case, probably it's not the right thing to do, but it's reasonable to think of it and ask the question, I think.
Okay, good. Oh, Tony.
So I just want a quick clarification, because I didn't quite understand. So you're saying that in certain cases, when you go in and do surgery, you're stopping imatinib or sunitinib or whatever drug the person is on. Why stop the drug?
So, yeah, that's a good point. You don't have to stop it for long. You stop it the day before, and then you restart it when you've when you've recovered, basically. But there's still a little bit of being the effects of the drug, and also the effects of the anaesthetic and the healing process and all of that. You know, the advice is to stop it, to help minimise, because if you have an infection, it might be made worse if you're on imatinib. Obviously, there's cardiac effects as well. So that is the advice that we follow. You pause the drug while patients are in hospital. But sometimes, particularly then if you had a bit of a collection, let's say we had to take some pancreas out or something and it's leaking, and there's a bit of infection brewing inside the tummy, it can take a few months before we can restart it. So we've just got to be mindful of all that sort of stuff. But yeah, ideal world, you just get them back on imatinib as soon as.
Each individual is different. Isn't
Okay.
it? Right. Thank you very much. Show our appreciation. Thank you, Alex.